Tirthankar. Welcome everyone to our Tuesday masterclass webinar from the Department of Critical Care Medicine, Yashoda Hospitals. I am Dr. Kaladar, head of the Department Critical Care at from Yashoda Malakpet. So we have these sessions almost since 4 years, regularly conducting. So one Tuesday masterclass and another Tuesday interesting discussions. Every Tuesday we conduct these sessions regularly. So Dr. Venkatraman Kola sir, I think everybody he is the master. Today's session is neurological emergency. As everybody know, these patients come in very sick state. So the critical care interventions play a very important role, especially being a neurological emergency, right from the airway stabilization to until the basically from neurology point of view, monitoring, multimodal monitoring, and stabilization of all the vitals, and even everything like later on they require prolonged ventilatory support. So once the neurologists and neurosurgeons they secure aneurysm, it is all in the hands of the critical care people, and especially the being a neurological emergency, they play a very important role. So with this background, we will go to the topic. For this topic, I invite our two expert examiners, Dr. Kapil Boravake sir. Sir is the Director of Critical Care at Sayadri Super Specialty Hospital at Atpa, Pune. So sir is very well known and actively involved even in Society of Neurocritical Care. So yeah, we'll definitely going to get very good insights from sir. I welcome you, sir, on board.
Yeah.
Yes, sir. So I welcome Dr. Venkatesh Gupta, is the senior consultant from Aster Whitefield Hospital. Having a wide experience across from Narayana Rudalaya to Manipal Hospital, and now is there in Aster Whitefield Hospital. So he will definitely will be providing very good insights into how to manage and how to proceed generally whenever we encounter these type of cases. So to present this case, we have two our students from Yashoda Hospital, Secunderabad, Dr. Sandeep, the R&D student, and Dr. Madhav, the registrar. Both are going to take us through the case, what they managed in their ICU. And at any point, our examiners will intervene and ask the questions. And as we go through, we'll get more and more insights. So I welcome all the attendees who are joining with us today. And you can actually interact in the chat box, whatever like questions and answers, your responses, please put in the chat box. So at the end, we'll have a total overview. So I think Dr. Sandeep and Dr. Madhav, you can both proceed presenting your case.
Okay, sir. Good evening, sir. We had a 50 years old male patient who presented to our emergency room with a history of sudden onset of severe headache, almost diffuse in type, from 1 to 2 hours. On the way to hospital, almost on reaching the hospital, patient had an episode of generalized tonic-clonic seizures with uploading of eyes and rolling of saliva from mouth, which was followed by decreased sensorium or decreased responsiveness. There was no history of vomiting, fever, limb weaknesses, blurring of vision, ear pain, or discharge. There were no history of headaches or any of the similar conditions in the past. He is a known hypertensive on tablet bisoprolol, amlodipine, and he was on atorvastatin. He was a businessman by occupation. His bowel and bladder habits were regular. There are no history of tobacco or alcohol intake. There was no similar complaints with the family members. On presentation to ER, the vitals were heart rate of 108 per minute. BP was 170 by 100 or 106 Hg. Patient saturation was 80% SpO2, requiring 6 liters of oxygen support with 6 liters of oxygen support. Respiratory rate was 24 per minute. The patient GCS was E2 V1 M2 with pupils bilateral 1.5 mm sluggish reacting to light. ABG was taken. It was showing combined respiratory.
What can I enter?
Yes,
Someone. What is your probable thought process at the end of history before going to examination?
So the patient presented with headache, which was sudden onset, and seizure-like activity, sir, which will most probably point towards some disorder or some disease towards the central nervous system, which can either be like stroke, subarachnoid hemorrhage, or CSVT.
Sir,
And what time of the day he has presented?
evening, sir.
Why this question have been asked? Any relevance?
Towards the end of the day, the patient you can usually have increased BP, which can present as hypertensive hemorrhage, or increased workload or increased stress, which can lead to any bleed inside the brain.
Venkatesh sir agrees with that.
Anything else?
Anything else? So, any variations, diurnal variations where some diseases are common in some time, anything like that?
Strokes are more common in morning, sir. Ischemic strokes. Migraine attacks are more common in the morning.
And why this negatives was asked about fever, limb weakness, blurring vision, any relevance? What do you wanted to rule out?
Uh, Patient came with actually history of seizures and headaches, sir. Any mid-brain involvement can present with limb weaknesses or even the anterior part of the brain. Patient can have blurring of vision in cases of any hemorrhage, like subarachnoid hemorrhage, or with meningitis. History of vomiting can be present in patients with hemorrhage and even patients with meningitis. And ear pain or ear discharge to look for any source of infection which will spread towards the brain.
And history of trauma, sir.
And no history of trauma, sir.
You can proceed.
Initially,
I have one question.
sir, yes, sir.
So with that history, what is the most probable diagnosis you are thinking?
Most probably it can be sudden onset of headache along with the seizure-like episode, can be ischemic or hemorrhagic stroke or subarachnoid hemorrhage.
Subarachnoid hemorrhage. He presented with severe headache. So anything that differentiates this kind of headache from any other diagnosis?
These patients usually have sudden onset of severe headache, sir, which will reach the maximum intensity immediately, that is within 1 hour almost. And patient usually it has the worst headache of his life, thunderclap headache.
Okay. What about stroke or any other diagnosis? Would they present with this kind of headache? What are your DDs here apart from the stroke you said?
So CSVT can be there, sir. It
What
can be
is
a cerebral
CSVT?
sir, cortical sinus venous thrombosis.
Cerebral,
Sir, cerebral sinus venous thrombosis or cerebral amyloid angiopathy.
Mm.
But with all, and it can be a stroke, which with the hemorrhagic transformation. But with all these conditions, there will be prior weakness. There will be focal deficits followed by an headache leading because of hemorrhagic transformation. Here, our patient directly present with severe headache. So our suspicion directly goes for a hemorrhagic stroke, sir.
Any risk factors he has to suspect SAH, like past medical history? Any risk factors
Hypertension,
in
sir.
that?
only history of hypertension, sir.
Right. Okay, go ahead.
Initial EBG showed mixed combined respiratory and metabolic acidosis with high lactates of 4.5. In view of threatened airway, patient was intubated, and the post-intubation ABG showed a pH of 7.35 with a PCO2 of 38 and lactates persistingly high with a PO2 of 87.
Can you Just repeat this.
Sir,
Your comment. You had some diagnosis in the mind. It can
yes,
be
sir.
anything. It can be SOL also.
Yes, sir.
Anybody can first present with space
Yes,
occupying lesion for the first time with headache.
yes, sir.
That is also possible. So don't narrow down your differentials only to subarachnoid hemorrhage or to stroke, because for acute severe headache arriving in the ER, the differential diagnosis is huge, and many histories will also help you to probably come down to probably narrow down to your differentials also. So
Yes,
it
sir.
is not like only these two conditions. And then when you decided some diseases in mind and you have seen these patients' vitals, so what is your comment on that?
Why does the patient is having high BP, sir, BP of 170 by 110 milligrams of mercury, and saturation is also low, sir, 80%, requiring 6 liters of oxygen, and patient is tachypneic or almost respiratory 24 per minute.
So what are your priorities in management in ER?
Uh,
For securing the airway, sir. That's the reason we intubated the patient, because of the threatened airway decreased ECS. Then later on, his BP was slightly on the higher side, but because we were suspecting a bleed, we didn't aggressively treat the BP. And next was to oxygenate him well and get the PCO2 level to normal range.
So airway, breathing and circulation. So ABC in
Yes, sir.
critical care, whenever you are, have some approach, like the way should be, it's airway, breathing and circulation.
Yes, sir.
So what was probable the thought process why he has drop in oxygen saturation? I too didn't expect with this history drop in saturation, but patient had a drop in saturation.
it can be because of aspiration or secondary to hyperventilation, or any pooling of secretions causing any obstruction of airway.
Any other possibility for drop in saturation?
Hmm?
Any other possibility for drop in saturation? Release?
So negative pressure pulmonary edema, sir.
Okay.
Neurogenic pulmonary edema, sir.
Hmm.
And next,
Okay.
This ABG is before intubation.
yes, sir.
First TB is before intubation, sir. After intubation, PCO2 was 38 and PO2 was at 87, sir.
Okay. So what was the first ABG? Can you just tell me what is like diagnosis on first ABG?
Patient is
Echocardiography.
having combined metabolic plus
Oh.
respiratory acidosis.
What are the ways in which you analyze ABG? What is the first thing you do?
We first look for the pH, sir, and then
What is the diagnosis?
sir,
Interpret the ABG.
a patient is having mixed respiratory plus metabolic acidosis with high lactates with hypoxemia.
Is, is he compensating?
So usually compensation for metabolic acidosis will
Respiratory
go through respiratory alcoholism, sir, but here having mixed pattern, both acidotic.
What is the first step in ABG?
To find the primary disorder, sir, and here our primary disorder is respiratory acidosis, because the pH, bicarb, and the PCO2, pH, and they're going in the opposite direction, so we can take it as respiratory acidosis. Going for compensation, sir, respiratory acidosis, because the PCO2 is rising, the bicarb also should rise, but the bicarb is reduced here, mostly in view of lactates, because patient had an episode of seizure. So we are suspecting here to be a mixed disorder, sir, with respiratory acidosis with metabolic acidosis, sir.
The first step will always be validation in exam. If you have been asked about ABG, the first stage is always validation. Second, the moment you will utter metabolic acidosis, examiner will be very keen to know what type of metabolic acidosis. So what are the different types of metabolic acidosis you know, and what is the acidosis here? Or do you want some more data?
We would like to have the anion gap, sir, but we have because to know it is a normal anion gap acidosis or the high anion gap acidosis, sir.
Okay. And what happened after intubation?
After intubation, the PCO2
Is
levels.
after bag mask or connected to ventilator?
After connecting to ventilator, sir.
So what was your thought process when you intubated? What was your targets of pH, PCO2, HCO3?
Target pH should be around 7.35 to 7.45, sir, and PCO2 should be maintained between at least 35 to and less than 40. And the PO2 should be around 80.
Okay, and what is the rationale of reducing that PCO2 to certain? What is that called?
Patient should not hypo or hyperventilate, sir. Just to maintain normal carbia,
Okay.
we try to maintain the PCO2 between 35 to 45, sir.
But why?
Raised PCO2 will cause raised ICP, increase in ICP, sir. So to prevent raised ICP, we
We are
need.
expecting raised ICP in this patient.
There can be raised ICP, sir. Patient has low GCS with almost GCS less than 8.
Okay. Venkatesh sir, anything?
With the ABG given, what kind of acidosis you suspect? I know you do not have other information, but there are some clues.
High anion gap metabolic acidosis, sir, because lactates are high, sir.
Lactate is high. Okay, we'll go ahead. We'll move ahead.
Patient was on ventilator with FIT of 50% and rate of 22 per minute with 400 ml and a beep of 6. 3% as bonus was given, and injection levetostam 1 gram shot was given, followed by 500 BD. At this point, our differentials were stroke, which can be either ischemic or hemorrhagic, subarachnoid hemorrhage, cerebral venous thrombosis, meningitis, or any intracranial tumor.
So, how will you proceed from here to investigate what is the diagnosis?
So after maintaining the airway breathing circulation, we went for an MRI brain to look for any one of these diagnoses are present or not.
What are the modalities that can be considered for this kind of time evaluation during this kind of time?
We can take the USG machine and look for optic nerve sheath diameter, sir, just to look at this region ICP. That can be done. And then
CT brain.
CT brain, sir. But here we
Why
have
CT brain was not considered here?
In our institute, we have actually code stroke protocols, sir. Whenever the patient presents with features of stroke like seizure, headache, or any limb weakness, immediately code stroke is announced, followed by MRI brain is done, sir, actually.
Okay. In code stroke, can CT be performed? What is the intention in code stroke?
Initially, CT brain can be performed.
You directly do MRI in code stroke?
MRI can be done, sir.
only if there's no active bleed or if there's no normally CT you will see an active bleed, sir. If there's no active bleed and
We consider it as ischemic.
If it's a chronic bleed, then you can go for an MRI. And if there is a few infarcts which are not seen in CT, then we can go for an MR or MR angio, sir.
No, my question is, when you raise a code stroke, what is the first modality of imaging you do in your institute?
MRI, sir.
MRI and MRI.
MRI. Okay. Kapil sir, any comment?
Advantage of suppose you don't have MRI and this patient lands with you.
Then we'll go for immediate CT, so CT brain.
Okay. Fine.
Even in code stroke, many centers
Okay.
recommendation is initially CT is good enough. Our intention is to rule out if there is any intracranial bleed or not,
Bleed.
which is good enough for us to consider thrombolysis. Then you can consider doing MR angiogram to see if there is any clot or anything more. So that was the intention of asking this question.
And 3% NS has been used here. And what was the logic and anything else you have thought before giving this? And in your examination, was there any focal neurological deficit?
No focal neurological deficit, sir. Patient was moving all four limbs.
M2, sir. The response was M2, no, sir.
M2?
M2, sir. So we couldn't actually have a proper motor examination, sir, because he was already an altered sensorium. We suspected it to be a raised ICB. That's the reason we give 3% NS bolus, sir.
Okay, and what are the possible adverse effect of 3%?
3% NS bolus, it can also lead to this also adds to a non-anion gap metabolic acidosis, sir. It can increase
cause renal failure, sir.
renal failure.
It can cause volume overload. It can increase the intravascular volume.
Because more pulmonary edema, it can cause cardiac overload, sir.
Anything else? Any trials you are aware about using 3% normal saline in raised ICP? Any other thing related to any brain area where it can cause damage?
Sir,
Giving 3% saline at a fast rate, it can cause cerebral spontaneous myelinosis if there is any hyponatremia.
Because it's always kept in the mind about possible, particularly quadriplegic coming with such symptoms.
Yes, sir.
Okay.
Do we have sodium value for this patient? Preliminary ABG?
In the ABG, actually,
Not
it was
given, no?
it was there, sir. It was normal, sir, actually.
Any advantage of using mannitol instead of normal saline? Or you have preferred 3% in any specific reason for that?
Mannitol is with more complications like osmotic diuresis, which can cause hypotension, which it can cause renal failure. It can cause coagulopathy. So 3% was more preferred, sir.
What was his blood sugar? Does that got some relevance? Headache coming with convulsions. I didn't see any blood sugar in this. In your preliminary examination, does it has value?
Patients who have hypoglycemia can present with seizures, sir.
But your, I think your record still now has not mentioned anything about blood sugar.
What are all the basic investigations you would like to know in this kind of patient when they present with, apart from ABG?
Electrolytes need to be seen, sir, actually, to look for any hyponatremia, hypocalcemia. And
Blood sugar, what else?
temperature also, sir.
Temperature. Anything else?
any history of drug intake or intoxications.
Okay. Anything else? What comorbidities he has?
Only
Hypertension.
Hypertension. Okay. In drug history, anything important in this kind of setting where you're suspecting bleed in the brain or a stroke,
Any issue of antiplatelets or anticoagulants.
anticoagulants? Yeah. So
Substance.
you will probably even ask for PTI now, isn't it?
Yes,
Yes.
sir.
Yes. Okay, Kapil sir, if no question, we will
Yeah,
move
we
forward.
can proceed. Yeah.
Later, the patient was shifted for MRI brain, which showed large over altered signal intensity in the area of the basal distance with subarachnoid bleed and IVH, possibly representing the ruptured left PCI artery aneurysm with hemorrhage. Even there was mild diffuse cerebral edema was present, and obstructive hydrocephalus involving the bilateral lateral ventricles and the ventricles was present. This was the MRI which was showing IVH and bleed in the systems.
So what is the grade of SAH this man has?
According to modified Fisher, this patient is having grade 4 SAH, sir. That's thick SAH with IVH.
Okay,
And
what grading you generally use to prognosticate and how the modified Fisher helps you?
Modified Fisher helps us to
degree of
predict the
freedom.
risk of further complications like vasospasm and DCI. And high grades like uh, modified Fisher 3 or 4 are associated with the increased risk of delayed ischemia.
Okay.
And
So any other scoring that helps you to understand before intubation, what is the scoring that you could consider these patients? SAH grading.
Hunton has class, Hunton has grading, sir. That was also grade 5, sir, because patient was morbid condition and with disabled posturing. He was in grade 5, and the NWHS classification, that was also uh, grade 5, sir, because DCS was less than DCS was 5, sir. DCS was less than 6 with motor without motor deficits.
So what does that help us? How does Hunton Hess and WFNS help us?
Outcome and prognostication to the attenders, sir. Any
Okay.
with grade 4 and grade 5 it has a high mortality of more than 50%, sir.
So at this stage, Kapil sir is the relative. Can you please explain him what is it? What is the situation? They're very apprehensive family. So now you have a diagnosis. Now you have stabilized the patient. Initial hemodynamic resuscitation you have done, right? You have done the basic investigations, and now you have the MRI also. Family is eagerly waiting. What is your counseling to the family?
So we will tell that this patient is having a severe bleed inside the brain uh, with a high degree, which requires immediate intervention. There is a source of bleed, like aneurysm, which is present in the brain, which needs to be uh, closed or to the in the local language. It should be, uh, you know, prevented from further rebleeding. We need to either apply a clip or coil. And this patient, since he is having low GCS, there is a high risk of morbidity and mortality. And also, if the patient recovers, he has the improvement of GCS might take a long time, along with complications.
Let's Dr. Madhav, let's assume you're talking to family.
So first, take the attenders in a comfortable space.
Mm.
Listen to their what are their expectations, like what have they come with, what do they expect from us. Then tell them what has happened. Initially explain them, because they would be in a very distressed time because they have seen sudden desaturation, sudden headache. So explain them
Expectation is good outcome.
their expectation is
Expectation
good.
is good outcome.
First, just explain them how the motor response is. The patient had come with a very poor motor response, very poor GCS. Explain about that. Then tell them the about first we have secured the airway. Tell them what the image showed. Image showed a massive bleed. Tell them what is tell them what is the mortality of such a massive bleed. Explain them about the complications. Explain them what are the interventions we can take ahead, and expect tell them what are the choices they are having, what all we can do, and what all they from their choices. Explain them about the cost and cost ratios about all the procedures, and then give them time to take a decision, sir. But tell them
Okay,
ki,
but
a faster.
no,
Yes, sir.
let's come to the point. You convince now the family what you want to do.
Our main plan is to.
What have you planned? What have you planned?
Our
So
plan is to.
this is what is going to happen, right? You are going to face. You have done the imaging. You are the person who is facing the family. Now you have to tell what is it and what is your plan, and you convince the family now.
Our plan is to explain them there's a ruptured aneurysm. We explain them about what is about the brain arteries. There's a ruptured aneurysm. Our main aim first is to control the bleed, and the control of the bleed. If it is not done now, then the prognosis is only going to worsen. To explain them why the intervention is so important to be done now. Explain them the need of a DSA for a explain them what are the benefits of the coiling, but even tell them such procedure will lead to a bit better outcome, but it is a prolonged outcome, sir. Explain them both pros and cons of the procedure, sir.
So, what is the next step?
Our next step is to go for take in our intervention radiologist, sir, and go for a DSA, sir, and plan for an coiling, sir.
Dr. Kapil, you want to ask anything here at this junction?
Yeah, like the first step will be what is the gold standard for diagnosis of SAH, and particularly when you have to decide about the interventions, what is the gold standard?
DSA, sir.
DSA. So before DSA, will you be talking to the family
angiography,
about
Cerebral
aneurysm
angiography.
coiling clipping?
CT angiographies.
No, before DSA, will you be talking to family about like you don't want to confirm on DSA?
Since MRI is showing features of posterior aneurysm, sir, which is most amenable to coiling. So initially we explained about coiling only, sir, actually.
Which aneurysm is easily amenable for coiling? Which is difficult?
Posterior aneurysms are more amenable for coiling, sir.
Posterior circulation aneurysms are little difficult to for the coiling, unlike the anterior circulation ones. But yes, it is possible. But in comparison, posterior ones are little difficult. But now you do not know whether patient is fit for coiling or not. That's what Dr.
Not.
Kapil is telling. That
Yes.
is what you are going to tell the family, that we need to take him up for DSA and procedure, right? And the importance of securing aneurysm as early as possible. How early you should consider it? So family tells, no doctor, we want time. We keep in the ICU, we will decide tomorrow.
Most of the time this
Mm.
happens.
They want to ask doctors, they want to ask family, they want to arrange funds. They have brought 1 lakh rupees now. They have limited funds. They can arrange, but keep the patient in the ICU, doctor. Tomorrow we will see.
Early intervention has better outcomes, sir. Studies have shown that early intervention within 24 hours has better outcomes. But even from 24 to 72 hours, interventions are comparable even with less than 24 hours.
So by securing the aneurysm early, what are you going to prevent?
We prevent rebleeding.
Vasospasm.
Vasospasm. Are we going to prevent vasospasm?
Rebleeding we can prevent, sir, actually.
There are good chances that you are preventing rebleeding. Securing aneurysm, will it assure you that there is no rebleeding afterwards?
Rebleeding can happen, sir.
Yeah, even after securing aneurysm, rebleeding can happen, but definitely it reduces. The risk of rebleeding reduces. When is the risk of rebleeding highest? What is the highest risk of rebleeding in terms of duration? When is the highest risk of rebleeding?
Like 24 hours. Within 24 hours, sir.
Within 24 hours, right? So securing aneurysm as early as possible always helps. So the next goal you are going to tell them is to identify the PCA aneurysm, the size, whether it is amenable for coiling or not. At this junction, I don't know whether I will be able to ask for coiling or not. Right? You have to evaluate further. There comes the role of DSA or any other modality we can do to understand the aneurysm. You have done MRI, understood, but you may not be able to pick up everything unless you have given contrast, isn't it?
CT angio can be done for the
CT angio, but the gold standard is
DSA.
DSA. What is the advantage here? In this patient, you sending for DSA, what is the advantage? At this point of time, there is advantage of sending him for DSA, right?
Both diagnostic and therapeutic intervention can be done, sir.
Therapeutic intervention can be performed in the same setting. Yeah,
Setting,
if
sir.
it is amenable for coiling.
Coiling, sir.
Okay. So what aneurysms are not possible for coiling? It's all neurosurgical or interventional radiology field, but we should know certain things for the initial counseling also, right?
Any wide neck,
Internal carotid artery aneurysm, sir.
Okay.
Then
Wide-necked, irregular,
wide
fusiform.
neck
Yeah, but still they may consider depending on the fundus and neck ratio. They look at the fundus and neck ratio. Okay, and if the neck of the aneurysm is more than 4 mm, then it may be little difficult. So based on all these things, further decision will be made whether patient is fit for coiling or surgical clipping, right? So that's what we are going to tell the family. Kapil sir, any question?
Yeah. In the same scenario, is there any possibility like this patient will come to you in the hospital? Here you are lucky that you have picked it on MRI. Suppose same patient has come to you, you have done CT. He has come, I think, within 1 or 2 hours to you. You have strong suspicion of SAH, but his CT is normal. Here you are lucky, but there will be a situation where your CT is normal.
yes, sir.
So what will you do? But you have strong suspicion of subarachnoid. Your CT is normal.
We can either go for repeat CT or we can do lumbar puncture after 6 hours.
You will wait for 6 hours for lumbar puncture.
Then 2 hours also we can get xanthochromia, sir.
Yes. You can do lumbar puncture within 6 hours. The question is asked for a specific reason. What is the role of CSF studies in subarachnoid hemorrhage? Beyond, within 6 hours, after 6 hours, with normal CT.
It is advised to do after 6 hours. Sir. It is advised to do after 6 hours.
Any specific reason?
Pigment formation, so from the hemoglobin to the biliverdin formation and resulting in CSF that takes duration of minimum 4 to 6 hours. Sir.
So, can you talk in terms of sensitivity and specificity? Is it 6 hours or is it 12 hours?
Yes, the guidelines are told if it is more than 6 hours, LP can be done.
And what will you see in CSF?
Xanthochromia can be seen.
Yellow color pigmentation.
Okay. Anything else?
How do you say if it is? How do you say that? How do you look for xanthochromia? Sometimes you should ask the biochemistry team or the pathology team what you want, right? Otherwise, they may not look for it. Suppose it can be, if suppose it is a traumatic lumbar puncture. How do you differentiate traumatic lumbar puncture versus SAH? These are few scenarios which you may face. practical challenges?
Centrifugation of the sample, sir, and later checking for any segmentation.
Yeah, centrifugation leading to the supernatant xanthochromia. Okay, that's what you look for. The other way of looking at things is a rough guide for RBCs. What happens if it is traumatic CSF versus SAH?
Increase in number, sir. In traumatic.
In traumatic, increase in number. What happens? We'll collect 3-4 samples, right? And all 4 samples you look for the RBC count. What happens if it is traumatic?
Gradual decrease in the number of RBC counts.
Gradual. Yeah. In SAH, it may be the same most of the times.
Yes.
Most of the times it will be the same or it can increase. Okay. Okay, we'll move ahead in the case.
Patient was shifted to emergency digital subtraction angiography. The DSA was done, which is showing a large left PC aneurysm, about almost 16 to 14 mm. The microcatheter was navigated into aneurysm sac and packed with multiple detachable coils. And check angiography was done, which showed adequate stasis within the sac. And we have obstructed hydrocephalus, and neurosurgery opinion was taken, and extraventricular drainage was placed.
Okay. So coming to hydrocephalus, why hydrocephalus happens?
Because of the obstruction by the clots.
Where exactly?
At the level of cerebral aqueduct.
Cerebral aqueduct. So when do you expect, how early you expect hydrocephalus as a complication?
Normally after 24 hours, sir.
Is it 24 hours here?
No, sir.
No, sir.
It can be as early as possible, but generally it can extend up to the risk of hydrocephalus.
Up to 1 week also, sir. Patient, it can come after a week also, then patient will come with gaze palsy, decreased weakness. It can even come after a low decreased increased neurological deficits. After 1 week of SH also it can happen, sir.
Okay. So this patient has undergone coiling, right? So is coiling better or clipping better? If suppose you are explaining the family, both options you are giving. If suppose he is amenable for both the therapies, and here it is quite wide and big aneurysm, right? 16 into 14.
Yes, sir.
Okay, such big aneurysm generally they would have used some adjuncts also along with coiling. Otherwise, it is very easy for. What is the risk of coiling that either you or the interventional radiologist explains to the family? Risks of coiling.
Risk of rebleed, sir. Rebleed, there's a risk of rebleed with coiling when compared to clipping.
Compared to clipping, okay. Apart from that, any other risks? Any risk of thromboembolism?
Yes, sir.
Compared to clipping, there will be some amount of coil dislodgement or risk of thromboembolism in this group of patients whom you are opting for coiling. So is coiling better or clipping better? The family asks you.
Both has its own advantages and disadvantages, actually. So clipping it is more invasive, associated with more blood loss, but comparatively less chances of rebleeding.
And coiling can be done as a both. It is a both a therapeutic and a
Yeah.
diagnostic, sir. In one setting only, both can be done. There is better outcome when compared to coiling when compared to clipping. After like 6 months or after 10, longer outcome is better with coiling when compared to clipping.
Any study, any landmark study you can quote to say that coiling is better than clipping?
Exact trial,
I
sir.
said.
I said so. What it showed? What were the results?
So 6 months outcome when compared in patients with coiling and clipping, it was better. The outcome was better in patients with coiling, but there was increased chance of bleeding was there in patients with coiling when compared to clipping.
So essentially, they looked at good grade SAH. This study, the ISAT study, looked at good grade SAH. The candidate, the patient here is poor grade SAH, isn't it? So that ISAT trial essentially looked at good grade SAH. So they looked at 1 year mortality versus morbidity, which was better in the coiling group compared to the clipping group, right? And they also had less seizure. The risk of bleeding was slightly high, but statistically it was not that significant. All the trainees should be aware of the ISAT trial. It is a very important landmark trial. Any trial that looked at poor grade SAH who underwent coiling versus clipping?
Rupturism trial.
Grant.
Yeah. So what was the outcome in that?
There was a low rate of poor outcomes in patients who had been for coiling.
So it was the outcome was not different whether it is coiling or clipping, right? Okay. Kapil sir, you want to ask any questions? Yeah.
Any difference like when you are choosing between coiling and clipping, any relation with the age of the patient?
Advanced age or age more than 60 or 65 years, preferably patients should be taken for coiling.
Okay. Younger patients?
Clipping is preferable if it is amenable.
Okay. ठीक है. Yeah.
Based on
After that,
reported.
are there any slides?
Yes, sir.
Yes, sir.
Yeah.
Later, after the procedure, the patient was shifted to Neuro-ICU. On examination, patient GCS was E2, VTM2 with people 1.5 and sluggish reacting to light. And the patient was maintaining vitals with the saturation of 95% with FiO2 of 40, P of 6 and tidal volume of 420 ml. And pulse rate of 85, BP of 148/90 and temperature of 98.2. And his GRBS was 1.168. When ONSG was done, right eye was showing 0.6 and left eye 0.62. And since EVD was in place, ICP monitoring was done with EVD on day 1, which was usually between 15 to 20. And the patient was continued with analgesia and sedation. Time nimodipine was continued at 60 mg 4th hourly. Levetiracetam was given at 500 mg IV BD. And the 3% was continued at 50 ml per hour, and supportive care of fast track bits was given. So we continue, sir. ECG was taken, which was normal. Echo was showing fair LV function with no RWMA. And EEG was done in view of patient was present with seizures. It was showing diffuse generalized slowing. And the patient was continuing with nimodipine, 3% normal saline, levetiracetam, analgesia, and sedation. Investigations showed hemoglobin 14.2 with the WBC 9000, electrolytes, sodium of 139, and the PTNR was 13.6 and 1. On day 2, still the Jesus was persistently low, E2, V2, M2 with the pupils 1 to 1.5 mm, sluggish reacting to light with the serum sodium of 146. and EVD drain was blocked, so we couldn't monitor EVD from the second day.
Happy on day 2 post procedure, and what the relative counseling?
Counseling to attend us, sir.
Are you happy with the progress or are there any issues?
The GCS is still persistingly low, which shows the high degree of injury that the patient has suffered because of the aneurysm rupture.
How do you monitor? I know you said couple of the monitoring things, ONST and all that. What is ONST telling you here?
Optic nerve diameter will tell whether the patient is having raised ICP.
No, here the values that you have put up, what is it telling?
The patient is having raised ICPs.
So how are you managing this patient with persisting raised ICP? How are you monitoring this patient for complications of SAH, especially with relevance to SAH?
One thing we need to monitor the ICP of the patient, sir. Initially on day 1, we monitor the ICP with AVD, and based on that, 3% NS was given at 50 ml per hour, and if required, intermittent boluses was given.
And elevation of 30 degree was given, sir. Patient normocarbia was maintained. Temperature was normothermia was maintained. No neck movements. Neck positioning was put in a proper position, and then
Was the sedation?
and sedation was given, sir. And patient was in sedation was given to the patient, sir. He was on.
So you are sedating this patient. So this is a situation because of the raised ICP, you are taking all these measures, but you want to monitor the complications of SAH. What is the next dreaded complication that you anticipate in this kind of patients at this stage? Family is also apprehensive, is still sedated. You're intermittently assessing the GCS E2, VT, M2. You are looking at the EEG. So what else is important to monitor in this patient? What do you monitor for?
On day 2, we mainly look for the features of raised ICP.
Okay.
And sodium monitoring.
ICP is done, you are managing ICP. Along with that, you anticipate some complications of SAH.
Vasospasm.
Meningitis, sir. Because
Meningitis. Okay.
And
Meningitis, yes, but more relevant to SAH we are discussing. Yes, meningitis is important. That's an ongoing thing because you have put TVD and all those things, right? More relevant to SAH. Vasospasm, yes. How do you monitor vasospasm in this patient, heavily sedated because of the raised ICP and all that?
transcranial Doppler was done, sir.
Sorry,
Transcranial Doppler.
Transcranial Doppler, sir.
Transcranial Doppler. Okay, TCD is done. Right. That is one of the good modality to monitor ICP. So do you do it regularly?
Yes, sir. We did it once daily.
Once daily for this patient.
And the CT angiography and CT perfusion can be used to detect vasospasms.
Yes. So what are the measures you have taken to prevent vasospasm in this patient?
We have started the patient on early nimodipine, sir, at 60 mg every 4th hourly.
What are the side effects of nimodipine that may happen, which you may face while managing the patient?
Hypotension.
Hypotension. So what do you do? Will you stop nimodipine?
Either we can decrease the dose and increase the frequency, or start the patient on noradrenaline.
So your flow velocities in the TCD is all well maintained. It's not very high peak velocities. Okay. So will you consider the triple H therapy in this patient?
This triple H, sir, is asking about.
Triple H is hypervolemia, hypertension, and hemodilution, sir. hypervolemia and hemolation, they can cause cardiopulmonary complications. In this patient, hypertension that is maintaining systolic BP around 140 or MAP around 80 to 90 can be considered to prevent vasospasm.
Okay. Suppose when do you consider augmented blood pressure? Hypertension.
When the patient is having any severe vasospasm,
Proven
systolic
vasospasm.
BP around 160 can be considered, sir.
Yeah. So in a patient with proven vasospasm, then only you are going to consider augmented hypertension, right? Mm. Dr. Kapil?
Yeah, move to next slide. Yeah.
On day 3, the GCC was persisting in with E2, V2, M2 and pupils of 1.5 mm, which are pinpoints against reacting to light with serum sodium 150 and EVD drain was blocked. There was no drain output, and TCD was done, which was showing mean flow velocities of around 160 to 170. At this point of time, intermediate opinion was taken, and there was no active injection from their point, and the patient was started on midrange infusion. On day 3, CT brain was repeated. There was no interval change in the subarachnoid hemorrhage in the bilateral cervical spaces and basal distance, and still there was persistent cerebral edema, and EEG was still showing diffuse generalized slowing. Day 4, still the GCS was persistently low with E2, VT, M3, and pupils bilateral 1.5 sluggish reacting right with serum sodium of 154 millimoles per liter, and PTNR of 14.5 and 1.2, and TCT showing velocities of around 140 to 150. Even on day 5, the patient Jesus was persistently low with E2, VT, M3, and pupils bilateral 1.5 sluggish reacting to right, and serum sodium 154, and TCT showing high mean flow velocities of 170. At this point, repeat CT was done, which was showing interval decrease in the subarachnoid hemorrhage in bilateral cerebral surface spaces and basal distance, but edema was persistent. Hence, at this point of time, patient was planned for decompressive craniectomy along with tracheostomy, and since the EVD was blocked, there was a plan to change the EVD to opposite side. Except for this patient today, decompressive craniectomy and tracheostomy was done, sir, and EVD was changed to opposite side.
Any more slides left?
No, sir.
This is this milrinone is IV milrinone you have given?
IV milrinone, sir.
Any evidence for IV milrinone? This is for vasospasm?
Vasospasm,
That
sir.
is-
To treat
How do you
vasospasm.
how do you treat vasospasm?
Vasospasm, it can be treated with drugs like IV milrinone, sir.
Hmm.
There are many trials coming up, sir, where they are comparing oral nimodipine with IV nimodipine. Then there are trials which are comparing IV giving closer sentence conscious one trial. Then there are trials which are even comparing magnesium sulfate, sir. But they're to reduce vasospasm or refractory vasospasm, sir.
What do you do now? If suppose you have a proven vasospasm, what do you do now? I mean, just nimodipine is going on, right? Milrinone, IV milrinone, I'm not sure about the evidence for IV milrinone. But is there any other modality you administer milrinone?
We can give intra-arterial milrinone or nimodipine.
Yeah,
To reduce
intra-arterial nimodipine. And any other thing? Minimally invasive.
Stents can be placed.
Angioplasty, sir.
Angioplasty.
Angioplasty can be considered.
Within dilatation.
Right. So what do you think is the prognosis for this patient? How is he doing?
This patient is having persistently low GCS, sir. He requires usually a prolonged time to recover.
Okay.
There are no other complications. If there are no other new complications that are coming to patient.
Will you use any, suppose we have to counsel the family and how long is going to take, how much functional recovery is going to happen? How will you tell the family about the overall outcome?
We'll explain the family that from the time the patient has come, we have succeeded in securing the bleed, and there are no further episodes of bleed. But the patient, since he had presented in a severe SAH, patient has got vasospasm. Even for that, we are treating the patient, and we expect a decrease in the vasospasm. But since the patient is having so severe GCS, our plan is to wean the patient from ventilator. That we do by doing tracheostomy and weaning the patient to either BiPAP. And patient should be closely monitored, and patient is advised nimodipine further and levetiracetam further, and active chest and limb physiotherapy along with other supportive care.
Yeah. Till now, what you have done is what you have explained to the family. What is the next goal and how is he going to perform? What is it going to be the functional outcome? How are you going to explain to the family? Till now, you told them. Is there any established infarcts, cortical infarcts in this patient?
No, sir.
Yeah, and one more thing, what are the probable reasons do you feel that that has led to the delayed recovery? What are the differentials? Like we are talking about vasospasm,
Yes, sir.
but before talking about vasospasm, are there any other things that you should look into this patient to understand what is the cause for this low GCS for this patient? What are those
Presentation was
parameters?
high grade SAH, sir.
This is?
High grade SAH.
That is okay, but along with this,
Obstructive hydrocephalus.
one second,
And persisting cerebral edema.
then beyond brain, anything that can impact to his recovery or mental status?
Myopathy. Critical illness polymyopathy, any infections, and
Any metabolic parameters?
sodium and hyperglycemia scan.
Anything else can happen in this patient? For suppose you have addressed all the issues. There is you have proven there is vasospasm and you have addressed it. You have continued augmented hypertension. All those things you have done. Still the GCS is poor, not explained by the imaging. Anything else you suspect in this patient? You have already started some medication.
Any infections?
Infection.
What are you expecting in EEG? Anything else that can give you a
Absent
clue there?
seizures.
Peaking of alpha and beta waves.
It can lead to
Low degree sensorium.
non-convulsive
Unconvulsive
Seizure.
NCS.
non-convulsive status. You should always think in these patients, and that's why continuous EEG is very, very important in this patient. And what is mean by delayed cerebral ischemia, and how you differentiate delayed cerebral ischemia from vasospasm? Or
So
when you suspect delayed cerebral ischemia?
the delayed cerebral ischemia is more of a condition, sir, where a patient will develop new neurological deficits within and one are acute development of neurological deficits.
Usually there
Vasos
is a drop in Jesus by more than or equal to 2, sir.
two. And vasospasm is more of a radiological finding rather than clinical findings. And DCI is more of a clinical finding.
Anything else between these two? Any differentiating points?
It usually occurs between 4 and 14 days DCI.
Does sodium is going to play a part in the sensorium, and are you happy with these sodium values? And your target sodium in your hypertonic saline therapy?
Is to maintain around 150 to 155, sir.
So you're happy here with like
Yes, sir.
it was 150, I guess
Yes.
51 or
Yes.
something.
Yes,
Yes.
sir.
154, I think.
154, sir.
So still 3% is on.
We had stopped when the sodium reached 154, sir.
Okay. ठीक है.
So, with this severe grade SAH, the patient has come, has spent already lakhs of rupees. They're anticipating what will be the overall outcome and how is what is the next step, or whether he is going to become better, fully conscious, and all those questions they have. So, how are you going to address that outcome? You have to give some direction, right? You have done so many things, intubated, tracheostomized, decompression has been done. No, all this will are going to increase the expectations of the family. No, how are you going to address those questions?
So first we tell that the patient has come in very severe condition, and we
We have
manage.
already we already explained that, right? He came with severe condition. What all
So
you have done, you have explained. So what is going to happen is that we can throw some light so that they have some idea how much more days, how many more days, how much more money to spend, whether he's going to stand on his toes, on his legs, and whether he's going to get back to regular functioning.
the patient still has a very poor GCS. He might request from somewhere around from weeks to months time to recover. And as of now, the plan is to wean the patient from the mechanical ventilator by doing tracheostomy and wean the patient to BiPAP. And if all other factors are permitting, the patient can be shifted to rehabilitation center.
Regarding neurological outcome, we have to show some light, right? Otherwise, the family will be clueless. How do you do that?
The repeat imaging is not showing any features of disease of ischemia, and even there is interval decrease in the SH. There are chances of patient recovering, but it usually takes some time for the patient to recover.
Uh, uh, I will always take help of the neurologist, neurosurgeon, and I will probably use some scoring systems to understand in this kind of high grade SAH. If it is a good grade SAH, we can always tell that the functional outcome is going to be good. But when they come with such kind of high grade SAH with so many issues happening, I always take help of some scoring systems to guide my counseling, and it is always multidisciplinary counseling which always helps them, including rehabilitation consultant if we always have uh, in in your setup. I'm sure we will have rehab consultants, neurology, neurosurgeons.
Yes.
That is how I'm going to counsel the family, because here the prognosis looks little poor, and he is definitely going to have some cognitive disabilities, some focal neurological deficits. I'm not sure whether the latest repeat scans, if you have put up, and if there are any cortical infarcts, because you have already have a proven vasospasm. These are all high risk factors for him to develop delayed cerebral ischemia, and they are all some poor prognostic factors that we always have to keep in mind. And that is how I would be doing the counseling to the family members, and that is what is expected from you in the exams. Even the initial stage, when I asked you have to explain the family, you have to explain in the lame language that they understand. And you are going to tell in the exam how exactly you are going to tell the family. Okay. And in this, in this process, what is more time consuming is explaining family, right? And making them understand the importance of early intervention and not delay the treatment when they said you can do it tomorrow, right? So those are all certain things that as examiners we will be assessing whether you are enhancing the importance of addressing the issue at that point of time by appropriately explaining the family members.
Then comes the importance of ancillary care in these patients is very, very important. So on that grounds, how will you manage his thromboprophylaxis? When do you start low molecular heparin? Yes, no, or any other means to prevent DVT thromboembolism?
Initially, the patient can be started on intermittent pneumatic pumps, sir. And when the aneurysm is secured, post 24 hours, if it is with coiling, we can discuss with the interventional neurologist, and then we can start the regomarcated heparin after 24 hours. If it is post surgery, then we can discuss with the neurosurgeon, and probably after 72 hours, then we can start regomarcated heparin.
And nutrition?
Nutrition should be started as soon as possible, as and when the patient is tolerating.
And optimized by day 5 to day 7, sir.
What is the regular ICU care things that you consider in this patient? You said nutrition and low molecular weight heparin. Other than that,
So the patient is in a morbid condition, to look for any bed source, have alpha beds, air beds, or and then
Feeding should be started as soon as
extra
possible, sir.
procedure.
And since the patient is on ventilator and the patient is having SAH, patient should be given analgesia and sedation. The patient should be given thromboprophylaxis with in this patient. Initially, we can start with IPC pumps, and head intubation should be done since the patient is having features of raised
fast
IC.
heartbeats, right? Fast
Yes,
Yes, sir.
heartbeats.
fast heartbeats.
Yeah,
Yes, sir.
that's what is very important. Like as Dr. Kapil sir was asking that only, right? And
I think
Yes, sir.
fine.
Yeah.
An important, as sir has already mentioned, that treating, after that prognostication, after that end of life care, all those issues, discussing with family, being open to family, giving them options, prognosticating. These are very, very important factors in these patients.
Yes, sir. Yes, sir.
Any
I think
famous personality you know who had twice SAH? नेटफ्लिक्स वगैरह देखते हो? Some actress in some, I don't remember the name now, from Game of Thrones. I think some Emily. She had SAH twice and she's acting again. So these kind of examples actually help encourage patients also, relatives also. I don't remember the name, but she's acting in a series called Game of Thrones. Some Emily is her name. I don't know.
uh,
She had SAH twice, been coiled twice.
somebody telling me there's a Clark.
Clark, yeah, Clark.
Yes,
So
sir.
you'll not forget SH. You'll read.
what is the role of anti-epileptics?
Yes, sir.
Antiepileptics can be started since whenever the patient is presented with seizures, or whenever the patient has presented with low GCS, or whenever there is presence of any MC aneurysm. or if there is any high grade, like Hunter's scale or the WFNS score, then the patient can be started on antibiotics, sir.
And it can be stopped if there's no prior seizure, sir. It can be stopped after if there's aneurysm after coiling. Antiepileptics can be stopped, sir, because there are studies which show that there's more worsening of condition after starting antiepileptics in patients who don't have prior seizures.
Yes, and if it is even if they have seizures, but for example, this patient only 1 week of therapy is what is generally required,
1 yes, sir.
right? Phenytoin, can we choose phenytoin?
No, sir. Phenytoin is not taken because of low therapeutic index and it can cause a lot of side effects. That's the reason phenytoin is not the first line of choice, sir.
Any other reason why phenytoin is discouraged now?
It can cause hypertension.
Any studies that has shown? There is a study which showed that there is a significant cognitive decline with the usage of phenytoin. That is one of the reason why, and of course now the usage of phenytoin has come down significantly in other conditions also. But with regards to SAH, that is one of the important reason that we have to keep in mind. All other things are there, but this is what is very important.
I think we have fairly covered, sir.
Yeah.
Yes, sir. I think very fairly covered. One interesting question, sir. Like in any patients who is having increased ICP, so when we are starting hyperosmolar therapy, something like 3% saline. So suppose a baseline sodium of that patient is at 130. How do you how rapidly you target that 150 to 155 that generally we talk? What is the time duration that you generally look at to go up to that stage of correction? Generally, we are worried most of the times any hyponatremia patient comes, we strictly correct within 24 hours, 8 to maximum is 12 milliequivalents in 24 hours. Whether we have to really
yeah, whenever there is disruption of blood-brain barrier, one of theoretical discussion is we need not worry, but we always are concerned about sudden rise in sodium. Theoretically, whenever blood-brain barrier is disrupted, I don't think we should worry significantly. But yeah, on the safer side, we still look at 10, not more than 10 to 12 over the 24 hours. This is always debatable, I think. Dr. Kapil, if you
yes,
have
sir.
different answer.
Yeah, I think very debatable as you said, but once the blood-brain barrier is disturbed, we are always worried for central pontine analysis. But looking at the recent papers, to achieve osmolarity or hyperosmolar state, we have to give. There are the two ways to achieve it. Either you can have a protocol where you will give bolus 3% normal saline looking at sodium. Maybe as sir rightly said, we will be not targeting more than 12 per milliequivalent per day. That will be our ultimate aim. And second will be the infusion protocol where we'll be not giving boluses, but we'll 6 hourly monitoring sodium to achieve. Because our ultimate aim is to not to achieve sodium, but to look at the osmolarity, and we are achieving has hyperosmolar state to look at the reduction in the ICP. And reduction in the
Another in,
ICP is ultimately again for better cerebral perfusion pressure. We are reducing
yes.
ICP's ultimate aim is to have a better perfusion pressures.
Yes,
As
sir. I think
Kapil sir said,
as
it is
you
not just sodium. It is not just sodium. Achieving adequate CPP is what is more important with all the measures of your tire therapies. That is the reason I was asking about sedation. This patient, you would have definitely sedated with a good amount of propofol or whatever is required. I think that is much more important rather than targeting only sodium.
yes, sir. Yes, sir. I think, yeah. So probably, I think in acute situation when very high ICP, maybe we'll target rapidly, but still we have to be careful about thinking about osmotic demanation, central pontine analysis to be considered very important. And another thing, actually, we recently had one patient come with something else, some headache and all, but in some fever and all, we were suspecting probably meningitis and all. When we looked at frequently CT angiogram was also done in this patient, and there was an unruptured aneurysm. So in this is a bit tricky situation most of the times. So how we generally go about these patients, generally unruptured aneurysms?
Again, there are guidelines for unruptured aneurysms. If it is, more than 4 mm base or something like that, or 7 mm base, it is advisable to consider clipping. I think again there are studies clipping versus coiling. Uh, I think, but long back I have looked at it. But definitely there are guidelines how to go about securing unruptured aneurysm. And especially this is much more common in the first degree relatives, first degree and second degree relatives of patients who have this rupture SAH, basically,
Genetic predisposition, yeah.
genetic predisposition.
Our
No,
interventional radiologist was telling that the flow diverter may be a better option as compared to
flow
clipping.
compared, I mean, I was just going through those guidelines regarding flow diverter when to use. There are specific recommendations when to use flow diverter. Patients with narrow-based aneurysms are generally who are amenable just for coiling. They should not put flow diverters. They all have some complications. So I think there is a specific group of patients whom we are considering flow diverter or stent based therapies.
Yes, sir. Yes, sir. Right. How do you
Then,
think, how aggressive we have to be in ICP
yeah,
monitoring?
sir has already
Sir.
said now about unruptured aneurysm is a very tricky situation.
This situation.
Again, what mostly is it depend upon the size, as sir has said. So the real worry is when it is in the mid zone. If it is too large, we know we have to do it.
Yeah.
If it is less than 4 mm, 5 mm, also we know that we don't. The real scene comes when that is between this 4 to 7, 5 to 7, what is to be done. And I think its location also makes a lot of decision making, as my colleagues from neuro, when we discuss. If they are into anterior circulation, they more favor to do it, even though size in borderline. But probably, I think there will be few guidelines.
Yes.
I'm not very sure, but
So there,
definitely to
there is there are studies and guidelines
yeah.
for,
Yeah.
but I cannot recollect verbatim as
Yes,
it
sir.
is, but definitely there are
Yeah,
guidelines. But
definitely.
as you said, your patient presented with symptoms, so probably it was enlarging
Probably.
in size. He may need therapy at that point of time. If it is asymptomatic, if you have evaluated for follow-up as a first degree relative, then probably you monitor it every 6 months to see the size. And if it is increasing, then I think there are
Then,
definitely studies and guidelines regarding
yes.
unruptured aneurysm.
Yes, sir. Yes, sir. Yes, sir. So one more question, sir. Like, how aggressive we have to be in instituting close ICP monitoring tools, something like intraventricular catheters and all. What do you think your experience like? Most of the times, the centers may not be opting for it. Even at our center, we don't very regularly monitor. But what do you think? It has to be whether it has to be very make it as a
Instituted.
standard of care or something like that.
In this patient, probably we would opt for monitoring because his ONST was high, and if we have facility, and he had EVD also, so
EVD also.
it makes things much more easier to monitor
Easier.
ICP in this patient.
Correct.
If suppose he didn't have ONSD, and if I have facility, I would consider monitoring ICP in this patient because the first 48, 72 hours, it always helps to monitor the ICP, and
Yeah.
especially if you are considering if there is especially intraparenchymal hematoma and raised ICP, it always helps to consider care. Becomes little easy for if at all you have to consider decompressive craniectomy. And
I think
Yes.
those who
we
have
have
missed, they can go and look at the debate what had between Dr. Venkat in this recent SNCC National Conference.
SNCC National Congress. Yes, sir.
Excellent debate. Try
Yes,
it
sir. Yeah.
about ICP monitoring invasive versus non-invasive.
Yes, sir. Yes.
I think every student should go through, and I think they will have a recording.
Yes, sir. Yes, sir. I think that was a very good lecture.
Very nicely been briefed by Venkat about
Yes, sir.
indications, pitfalls, limitations.
Yes, sir.
But as I said, as Venkatesh sir said, if in this case VVD was there, but otherwise in my unit also we are not doing ICP monitoring invasive for every patient.
Yes, correct. Correct.
Not
Yes.
every patient, but
Not
yes.
I think
This patient with EVD
EVD.
is a candidate for monitoring.
Very good, sir. Very, very good, sir. Very nice discussion. I think very happy to have you on our board and very good clinical insights from both of you. A lot of students will get benefited by this session. I think the key takeaways, timely ICU-based interventions, the role of critical care, along with close collaboration, multidisciplinary collaboration with neurologists, neurosurgeons, and even intervention radiologists plays a very important role, which changes the trajectory of these patients, of course, very, very important. So the critical care interventions timely. So I think with this, I think any closing remarks, sir? Regarding, I think one point I wanted to ask regarding the students' preparation for the exam, sir. One or two lines from both of you, sir. Preparation and the appearing by Viva and her, especially the Viva part, case presentation.
I think
English,
both of
sir?
you did very well, Dr. Sandeep and Dr. Madhav. Presentation was good, but it's just that this was a focused preparation. In the exam, it may not be the same situation. Most of the times, you can tell what you are doing as long as your practices are standard. And whenever asked, you tell what you do rather than quoting from the theory, and that should help. Regarding counseling, what you do, you have to tell. You don't have to explain that I will do like that, I will do like this. You tell exactly what you do in a real life scenario is what you are going to tell. That's how you are going to tell. Okay, if I ask how you are going to tell the family, you are going to tell me in the lame language what you are going to tell to the family. Those things are also important.
Yes, sir. Dr. Kapil, sir?
Anticipate questions before the examiner asks. That is the best way to prepare actually. And you know what kind of cases you are going to get. And they are very standard questions like at the end of history, what you have. They have a case vignettes. And every vignette will have a marks. So the exam pattern has changed. It is not like that one or two sections you if you don't do well. You get enough weightage for all the factors like your history, your initial assessment, your interpretation of labs, your ABC of management, then actual management, then prognostication. So every step has been put up as a 4 or 5 vignettes. So even if you are fumbling in the initial time, don't get disheartened. Just relax because you have another time. Few more questions are coming, and then you can actually make up for what some mistake has been done in the beginning. I think I anticipate questions before. I think that because most of the things you are doing actually in exam, as Dr. Venkatesh has said, what you are doing you should tell. If you don't tell what you are doing, then things become difficult to answer also.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
Yeah.
Thank you very much, sir, Dr. Kapil, sir, and Dr. Venkatesh Gupta, sir. And thank you very much, Dr. Sandeep and Dr. Madhav, for bringing out that case with a very good discussion that happened. And I thank our Yashoda Hospitals, our digital and branding team for providing the platform. Thank you, sir.
Yeah,
Thank you
thank you,
very,
Dr.
very much
Venkat.
and good
I
night.
think this is a nice
Thank you.
platform. It should go on and on. Our
Thank you,
good
sir.
wishes. Yeah.
Thank
Thank
you,
you, sir.
Dr. Kapil. Thanks, Dr. Kaladar.
Yes, sir.
Thank
Thank
Thanks,
you, sir.
Yashoda
Good night.
Hospital.
Bye.
Good night.